Thank you very much, Raj. Well, this is going to be a controversial area, but the first thing I want to say is don't shoot the messenger. What I wanted to do was give you an overview of how the commissioning policy is devised and where we are with it and the next steps. And then the second part will be talking about the National Penile Prosthesis Audit. If you think about NHS funding in this country at the moment, there are headlines there in the press, and they all relate to the funding not being enough for the expectations of the service. So we've got an older population, our interventions are more and more technically advanced, but the money just isn't there, and they keep coming out with these headlines. And I think we are in a bit of a crisis, and it's going to be fairly challenging for the years to come. So something has to give way. I don't think we can fund everything as we used to. I don't think everyone can have the treatments that they used to have. But obviously we need to try and preserve within our own subspecialties the interventions that we're offering. So if you have a look at the spending on the NHS as a percentage of the GDP, if you look over here on the last 7 years or so, just this area over here on the graph, that's been a sustained reduction year on year with regards to NHS funding. So what's the impact in our subspecialty? Well, I mean, already a lot of the units outside the ones that were already having specialised centralised commissioning were having to send in IFR, so individual funding requests, if they wanted to put in a penile prosthesis. Part of the problem is that I think on a whole, sexual dysfunction is seen as, especially male sexual dysfunction, as a fairly low priority clinical condition. But also what hasn't helped is that there is a tremendous variation in the distribution of units around the country. I think there's a higher concentration here in the southeast of units offering complex andrological procedures, whereas if you go to Wales or if you go further up north, then the units do reduce in number. So that again means that there is a discrepancy in terms of the men around the country who will be eligible or able to receive penile prosthesis or complex andrological interventions. But there are some things that the patients can do, and one of them is obviously one of the main issues with prostate cancer is that it does have issues as a late effects, so sexual dysfunction, urinary incontinence. So it does mean that as part, although they're surviving the cancer, they do have other side effects of the treatment which need to be addressed in terms of quality of life issue. It's also important for the psychological well-being. We know from the WHO criteria for male psychological well-being that sexual dysfunction is an important component. So again, the patients can argue this case. And finally, there's no real problems with regards to breast reconstruction after breast cancer, but there does appear to be a major problem with regards to dealing with erectile dysfunction after prostate cancer. So if you want to have equality between, if you want gender equality, then again, this needs to be addressed. The clinical commissioning policies came about a few years ago, and initially the NHS England devised a clinical reference group, which was just a group of experts brought in to give them advice. Now, they didn't bring up the policies as to advise NHS England with regards to two main areas, and the ones that they selected initially was penile prosthesis and surgical sperm retrieval. So I'll deal with each one separately. It's a long process developing these policies. So initially, the CRG meets with NHS England. They themselves do an evidence review, and this is where we have a real problem in these two conditions. When they did the evidence review, there was very little evidence on the role of penile prosthesis. The problem is that a lot of these studies are company-sponsored. A lot of them aren't randomized, they're just big case series, and that did result in very little evidence. So they came back to argue that we don't think penile prosthesis should be performed. There's no evidence, which we as clinicians know there is, because we've seen it. Someone has erectile dysfunction, which is end stage, you put in a prosthesis, we know they can have sex. So you have to argue your case on every point. So we were a little bit apprehensive. We thought this isn't going to go through. Once you look at their evidence review, look at their arguments, you think, well, there's no way that NHS England is going to fund penile prosthesis. But then once we looked at a different angle and brought in the patient groups where we feel that it's important that you address sexual dysfunction, and this includes patients with prostate cancer, pelvic surgery, and that includes rectal cancer, priapisms, then their views started to alter, and they agreed that if we developed our own evidence base, get additional experts involved as well, then they will be happy to take it to the clinical panel that eventually make the final decision as to whether centralized funding for penile prosthesis is going to be approved. And fortunately, after all of these meetings, discussions, they decided that penile prosthesis in England will be centrally commissioned, and it was supposed to have rolled out in April. I think things have now been a little bit delayed, partly because of the election and partly because there has been some queries from various regions in England regarding the policy itself. So they need to finalise it so there is no legal challenge in the future relating to the policy. But the policy is all available. It's all online, so everyone's got access to this. And what I've done is just brought out some of the main points which will be of relevance to those who are conducting penile prosthesis surgery. Now, one of the important points is that to be eligible for penile prosthesis, you do have to go through the algorithm of first, second line treatment. You can't just go straight to penile prosthesis without having exhausted this. So they will need to have pharmacotherapies. They will need to be considered for prostaglandins, either intraurethral or intracavernosal, before considering penile prosthesis surgery. Once you feel that they meet the criteria, there's also a BMI criteria, and they need to be well-controlled diabetics, and those who are diabetics, then they can be considered. The other thing that they've stipulated is that these cases need to be discussed within a benign andrology MDT as well, and undergo appropriate counselling before they undergo surgery, so that your patient selection is appropriate, because what they don't want is inappropriate case selection such that the numbers suddenly accelerate and people are having prosthesis put in inappropriately. So one of the things over here that I've just highlighted is that the men need to see either a nurse or the clinician for appropriate pre-implantation counselling. So the other thing in the policy is that there is a mandatory audit requirement. The reason that this was put in is because there was very poor quality data. We didn't really have any UK data to make our arguments, and although they put it through, they're now expecting that when the policy comes up for renewal, we should have UK data to back up exactly what we've done over the last few years. And this is one of the reasons that BAUS has taken this on board, and we've developed the National Penile Prosthesis Audit. So I have to encourage everyone who is putting in penile prosthesis that they need to put in their data onto Dendrite for the penile prosthesis audit. And what we decided was that you start your data from the beginning of 2016 and include 2017. When it was launched in 2016, we were hoping that 2017 would be prospective. I think a lot of us are all guilty. We haven't put on our data yet, but we've still got another 6 months, because we won't start analysing it until early next year. So please, put on your data, because that data will eventually be used by NHS England as well to see whether it's justified them centrally commissioning this procedure. So what I want to do is show you what we've done on the penile prosthesis audit so far. This is a breakdown of the centres. So this is data combined from 2016 to 2017. So remember, it is incomplete. We've got just over 200 cases that have been put on. And you can see that the distribution is such that there are still a number of centres which aren't really putting in a huge number. I think as with any procedure, if you're doing complex surgery, there should be an adequate number being performed in your center to keep your skills up and make sure that your outcomes are measurable. Because if you're only going to put in one prosthesis a year and that one prosthesis gets infected, straight away your infection rate is 100%. Whereby we've argued with NHS England, who initially came to us saying the infection rates are 25%. We argued, no, they're not. In large volume centres, it'll be 2% or 4% in high-risk patients. So you can see over here, the largest centres are starting putting on their data. We've still got a lot of data to put on. We ourselves are pretty guilty at UCLH because having done over 200 a year, we haven't quite put on all our data yet, but I'm hoping by the end of the year, we'll all be up to date. If you look at the individual surgeon volume, again, this group of patients, I think you could argue, are putting on enough cases annually that they're doing appropriate numbers. And this will probably come together and show that there'll be about 10 to 12 centres nationally that are doing penile prosthesis in a serious amount. Now, I know there'll be some centres that will argue that, well, we've actually IFRs, so we can't get our numbers up. But, there will be hopefully ways around it in terms of getting the numbers up, because when they look back at the data, there'll hopefully be enough. And I think 10 to 12 a year per surgeon is probably an appropriate amount. The other point I want to make was about consent. And once the audit was launched, later on, we had this slight problem regarding this section 251, which is about data protection and audit, particularly in terms of sensitive data. So if someone's got data being uploaded about their erections or their penis, etc., it is sensitive. So what we agreed was that going forward, please ensure that the patients know that the data is being collected for a national database. And what we do ourselves is on the counselling sheet that the nurses go through with the patients, we've got a tick box at the end saying that the patient has consented for data collection for the national audit. It's a bit of a catch-22 because the NHS wants this data for it to be collected, but then again, you've got some hoops to jump through in terms of collecting the data. So don't forget about the consent. And so far, I think we've been reasonably good because in 2017, which is the main group of patients that have been affected by this section 251, 91% have actually consented for their data to be collected and uploaded. But you can reassure them that it is all anonymized. The BAUS staff don't see their name or anything like that, but they will have their data onto Dendrite. Looking at the remainder of the data, if you look at the main patient groups that are having penile prosthesis surgery, it's not surprising. The highest group at the moment is the diabetic patients, followed by those who've had some form of prostatectomy. So this is a combination of open, lap, robotic, and then you've got 13% of those who had Peyronie's disease. So these are the main indications for penile prosthesis surgery. 2.7% complication rate is pretty good at the moment. We'll see what it is when the data is all uploaded, but this will be very useful when we come to renegotiate the commissioning in a few years' time, because again and again, a lot of our units have had arguments with the CCG saying that we don't want to fund this procedure because there's a 60% complication rate. So this is the whole idea of getting the national penile prosthesis audit underway, so we can go back at them and say, look, this is our national data, this is our complication rates, and it's not what you're suspected before. Specific complications, again, what we've done, when you upload the data, you'll have to give it a Clavian grade, and at the moment, there doesn't seem to be any major disasters. A lot of them are complications that we all expect, things like scrotal hematomas, the odd urinary retention. So at the moment, there's not been a huge number of complications to report. So just summarize on the penile prosthesis audit, we need to continue putting in our data. Let's try and get this all updated. It is a mandatory requirement if you're going to be doing penile prosthesis surgery, so I encourage you to put it on as you go. What we tend to do is I'll keep one copy of the PIF. So when you're filling in your PIF, just keep one copy, because most of the data that needs to be entered onto the database is already on the PIF. The only additional things is making sure that you've got the patient's weight, height, so you calculate the BMI, and also what you've done in terms of your antibiotic regime. There will be some follow-up data with regards to IIFs and quality of life as well. It is important, if you want to keep doing penile prosthesis, if we, in the UK, or, well, actually it's England, because it's an NHS England policy, if we want to carry on maintaining our service, then it is important we all get together and work collaboratively on this and ensure that we enter all our data. Okay, so the second clinical commissioning policy that's been started is obviously surgical sperm retrieval. Now, this was less controversial, partly because there are fewer centres offering this on the NHS, but also, the indications are fairly clear-cut. But it does now provide us an opportunity for urology to grab back some of the surgical interventions for male infertility and also ensure that they get a high-quality service in terms of diagnostics and intervention, because there are still a huge number of men who are deemed infertile and given no hope and given donor sperm, when actually, they do still have either a surgically reversible cause or there's an option of retrieving sperm directly from the testicles. So this will really focus on the investigation and management of the infertile male. This is our role, identifying these individuals where there may be either medical or a surgical reversible cause for their infertility. If it's surgically reversible, then it may be via microsurgical techniques or endoscopic techniques if they've got, say, for instance, ejaculatory duct obstruction. For the non-obstructive azoospermic patients, it's all going to be focused on appropriate surgical sperm retrieval. And what I've done is I've picked out the important points from the policy. One of them is obviously the indication for microteasy. I think the issue with regards to obstructive azoospermia who, for instance, aren't appropriate for surgical reconstruction, then doing a PISA or a straightforward teaser, I think it's gone too far ahead. That's something that urology as a specialty is probably going to be unable to get back and manage. I think the fertility units do it very well, and it's something that they can just carry on with. But what I think we need to highlight is the role of the urologist who's got an interest in andrology, who's trained up in andrology as a subspecialty in conducting microdissection TZ for those with non-obstructive azoospermia. And this is where the policy will highlight the patient selection, so the patients who will be suitable for micro-TZ. Also, you need to remember that those with obstructive azoospermia that have a failed PISA or a teaser, they can also go for a micro-TZ as well, and those who are post-chemotherapy or cancer surgery. So it does stipulate the patient groups. It also states that micro-TZ is the way forward for non-obstructive azoospermia. I think doing a teaser for NOA is probably now gone out the window. I think they should all be offered a micro-TZ because we know that it will offer you improved sperm retrieval rates. The debatable areas, I think this is going to be where the controversial areas and our fight is going to start, is really who does the micro-TZ. And I think at the moment, although there are a lot of individuals around the southeast that offer the service, if we are going to take this forward, a lot of units around the country will have to think about, if they are going to have an interest in this, offering the procedure, either get trained up or link up with the fertility units to offer this on the NHS. The pathway is all there and it's fairly straightforward, but I think as a group, we ourselves should be doing it because it does state in the policy that it's got to be undertaken by those who are accredited in scrotal surgery. And I don't know any other sort of specialty that has, a 6-year training program where they do scrotal surgery year in, year out. They've got indicative numbers, they get signed off for scrotal surgery. And, this isn't a procedure without complications. You can get testicular atrophy, devascularization, and it's not a procedure that someone who's untrained in scrotal surgery should be performing. But they may have to perform it because there's no local service. So this is where I think more and more units nationally will have to get on board and prevent future disasters such as this. So this is a case in Bury where a non-urologist has taken off a testicle when he thought he was taking an epidermal cyst. This is a case here from Stoke Mandeville where a general surgeon was doing an epidermal cyst and takes off the testicle, and he's been struck off. So these are the kind of disasters that we see when you have non-specialists performing scrotal surgery.
Let's see if we're coming up against time.
Okay, just want to summarize with regards to the pathways. There's one for obstructive azoospermia, which is fairly straightforward, and here you just highlight that there should be sperm there, and you can just do a PISA or a teaser. If they fail that, do a microteasy. And with the non-obstructive azoospermia, again, these are the ones that will have to undergo a microteasy. So the only other thing that's controversial is who's eligible. And one of the things that they stipulate is that the female should have funding in place for the IVF cycles, so for ICSI cycles, and then the male should be automatically funded. So looking ahead, finally, I think we need to look at ourselves nationally and ensure that men are offered this service. You need to liaise with your local fertility units, link up with your own trust, and if you don't have the expertise, there are enough courses and mentoring around the country that will help you go along and get us up and running. So I'd like to thank the individuals that were involved in the penile prosthesis, the extended members. Apart from the CRG, both David and Raj were involved. We had extended members on the sperm retrieval policy. I'd like to thank Sarah and Trish with the audit. Thank you very much.
So I'm sure there'll be a few questions from the floor. Well, while people are going to the mic, can I just say, as if BAUS, having done their bit in issuing very good guidance with the CRG, have been let down by NHSE, who's I don't know if anyone works with or for NHSE here, but the communication has been patchy, inefficient, poor, and it's been leaving patients, clinicians, and trusts in a state of confusion. There's been no clear communication about why things have been delayed since April, and no intelligible responses, not only about when things will be sorted out. I suspect it's in the long grass for quite a while, but what they're actually doing. We can't actually get hold of people to tell us what's going on.
Yeah, I think things were in limbo, partly due to the election. The other thing is that there have been some challenges to the policy. So the next step is those centres around the country who are already getting commissioned, they just carry on as usual. So they're already centrally commissioned. The slight problem is that they're now worried about legal challenges, and the next step is that there will be a service specification to highlight what these centres should have in place for them to conduct the surgery, and if they meet that criteria, then they will get centralised commissioning. So I think things have been a little bit in limbo, but it's going to take probably 6 months to finalise it. But in the meantime, what they're saying is that you just continue to send them to those centres which are already commissioned until we decide on which centres around the country are going to be eligible for centralised funding.
CJ.
Hi, Asif. Coming from Scotland, I'm slightly privileged and protected that we don't have commissioning in our healthcare system. And it's been successful to try and get penile prosthesis convinced for CRGs for cancer patients by drawing parallels and getting patient groups. My worry, and I guess my heart goes out for the other majority of patients who have metabolic syndrome diabetes. And my question is, what's the strategy about trying to convince CRGs and commissioning to take on and accept funding for these group of patients?
Well, I mean, it's probably going to be different in Scotland, but with NHS England, these are included. Apart from the fact that they've got to meet a BMI criteria, diabetics will get included, cancer patients get included. So anyone with end-stage erectile dysfunction who's failed those first, second-line treatments will be included.
Nigel?
For couples who have funding for an IVF cycle, we've been struggling to get the funding to do basic chromosomal analysis already, let alone the Y deletions. Who do you do the Y deletions on, and should it be funded?
Yeah, no, so again, if you look at the policy, if you read it, it will say that those who've got non-obstructive azoospermia do need to have a karyotype and a Y deletion. So it should be as part of the whole tariff.
I see if it was in implants, when you talked about 10 to 12, is that per centre or per surgeon?
Well, I don't think we've really come to a final conclusion. It's something that's going to have to be debated with them. I think doing one a month as a surgeon is probably ideal. It really depends on how many centres are going to be centrally commissioned, because then you've got to divide up the 600 that have performed around the country. So there's no point in having, say, 20 centres and then expecting each centre to do, 20 and then expecting 12 per, the 3 surgeons might be there. It's just not going to work. So once we decide on how many centres, you can then divide up geographically where it's likely these will be performed, and then see how many surgeons are performing them based on the audit, just as an estimate initially, and then decide on whether it should be 12 per centre or 12 per surgeon, because you do need to have a couple of people doing them in case of post-operative complications. If one person's away or goes off on leave or whatever, you need to have a backup.
I think as if we probably need a little tiny bit of pressure to get things moving. So, because there are centres who've set up their MDT, their infrastructure, their specialist nurse, everything right, and yet they're not being commissioned. And that data you presented really is not valid, is it? Because lots of the centres are actually not being allowed to. Some centres did 20 or 30 a year, suddenly being stopped. So, a policy that should have taken away healthcare by postcode actually promoted it, in a sense.
Yeah, it is. Well, it's a temporary thing, though, isn't it? It's going to be probably for another 4 to 6 months until they decide exactly what's going on. I think the data is good because we can make that argument. We can make the argument that because of IFR, a lot of these centres are ready to do it, but they haven't been able to do it. And so we shouldn't be restricting centres until they're given a chance and show exactly what the throughput is. So I think this is the importance of showing them data like this, such that we can make these arguments.
One final question. Have you spoken to the gynecology societies?
Not directly. We've had communication via the section.
Because this is going to wipe them out, isn't it?
No, not really. I think the objective is we don't want to stop them doing their PSAs or TSAs, whatever they're doing for obstructive aspermia. What we're trying to encourage them is that the NOAs should be assessed, and it is going to be a quality standard. It's a nice quality standard. The proportion of men with azoospermia that have been seen by a specialist. So there has been communication with regards to whether they provide any training for their specialists. So we've contacted the RCOG, the BFS, whether there's any specific training, and they say no, we do not provide surgical training for their members to undertake complex scrotal surgery. So that's in our half the pitch. I think there will have to be communication with regards to how a lot of the fertility units will want to now set themselves up.